Thank you for joining us today. This is the Kaye Family Learning Day, brought to you by the Saskatoon City Hospital Foundation. My name is Joel Heineman. I'll be moderating today's event. I'm just going to go over a few things here. So first of all, our agenda for the day, we'll do a quick welcome and introductions, and then followed by the Kaye lecture with Dr. Ezekiel Weis, and he will then be doing a few more talks as well. Aksa Salim, an orthoptist, will also be giving a talk here as well. And we plan to wrap up around 12:30 or so. So the Ludwig and Olga and Constance Kaye Pediatric Ophthalmology Endowment was established in 1998, and this was established as a tribute to Constance, or Connie Kaye, who was the only daughter of Ludwig and Olga. And the purpose of the Kaye Fund was to fund an annual lecture series relating to pediatric ophthalmology. In 2021, it was renamed the Kaye Family Learning Day. And then just recently, last year, Olga Kaye passed away. So now Marlene Conrad, who's a niece of Olga, has been appointed as the family representative. And this year marks our 22nd Kaye lecture series. We'll just go through some introductions for our speakers today. So first of all, Dr. Ezekiel Weis is an ophthalmologist with subspecialty training in oculoplastics, orbit, and ocular oncology. A native Calgarian, he received his undergraduate and medical degrees at the University of Calgary. He completed residency in ophthalmology at the University of Alberta. Following this, he completed 3.5 years of subspecialty clinical training in the areas of oculoplastics in Ottawa, orbital disease and oncology in Vancouver and Amsterdam, and ocular oncology in Philadelphia. In addition, he has spent 1 year completing a Master's of Public Health from Harvard University. He is currently a full professor at the University of Alberta and clinical professor at University of Calgary. He is the provincial medical lead in Alberta for the ocular brachytherapy program. He's the past president of Canadian Society of Oculoplastic Surgeons. His areas of expertise are orbital disease, ocular oncology, and corneal neurotization surgery. He has published approximately 100 peer-reviewed journal articles. He's presented close to 200 lectures, including 100 invited lectures. He's published 20 book chapters. His students have won over 70 research awards. He has trained close to 100 residents, was the primary supervisor for 12 fellows, with several of them going on to being major contributors in the field. He started the Alberta Ocular Brachytherapy Program, which has treated close to 700 patients since its inception. So welcome, Dr. Weis. Our other speaker is Aksa Salim. Aksa's career in ophthalmology began at Moorfields Eye Hospital, where she gained in-depth experience with various neurological disorders. This opportunity led her to further her ambition in becoming a specialist orthoptist. She received the Canadian certification from the wonderful program at Saskatoon City Hospital. Currently under the supervision of Dr. Ezekiel Weis, she has focused her practice and research in the fields of ocular oncology, orbital pathologies, and autoimmune disorders. She has been motivated to increase her knowledge and practice by expanding her expertise out to community ophthalmologists. So I'd like to welcome both of you.
Thank you for the kind words, Joe.
I'm going to stop sharing my screen here and just see here, Dr. Weis. I believe I've made you co-host, so I think you can share your screen when you're ready.
Okay, it's my thank you and good morning. A very kind introduction. I'm going to be using the first time I'm trying to present from the cloud, and so we'll see how everything goes. Can you guys see that screen there? Okay, perfect.
Yes.
And it says corneal neurotization on there. Excellent.
Yes.
Okay, so today we'll be talking about an exciting surgery. That story began about 10 years ago in Toronto, where the group at the Sick Kids Hospital, a group of plastic surgeons and a corneal surgeon, were trying to help some children who were born without fifth nerve function to the eye. And they thought maybe we could take a sensory nerve from the leg, the sural nerve, and attach it to one of the nerves in the face that is working, and have it connect to the eye and then restore function. I'm just gonna put you guys on hold for a second just to tell my kids to be quiet. Sorry about that, guys. And speaking of children with pith nerve palsy and some that are a bit too loud, that surgery really took off and became a game-changing surgery that now we perform semi-regularly for the right indication. So I'll give you a bit of background. I have no financial disclosures. I want to invite everybody, and Carson has already experienced this, to Alberta to enjoy the Rocky Mountains. You guys have that beautiful lake country up north, and we have our mountain country out west. And this is kind of the beauty that brought me back to Alberta. So our goals today is to describe the basic principles of transferring nerves, summarize our experiences in Alberta, and does this surgery even work? And show some key steps with surgical videos about this surgery, and talk about some new approaches that have been evolving over the last 10 years. Basically, neurotrophic keratitis, or loss of sensation to the cornea, is provided. Is a big deal because the cornea has one of the richest supply of innervation of all the body, 400 times the amount of nerve fibers per area as the skin. It is a degenerative disease of the cornea that results from loss of the nerve itself, which results in a sequence of steps resulting in injury. You lose sensation of the cornea. You get spontaneous breakdown of the epithelium, or traumatic breakdown of the epithelium that you don't notice. And then you have impaired wound healing because the body isn't able to sense the injury and isn't able to adjust its tear film and tear and blinking and all those other nerve-derived growth factors that help with healing. This is the most common causes. You can have the genetic causes, as in the children, like Mobius and familial corneal hypoesthesia syndrome. You can get it in diabetics, those with vitamin A deficiency. You can have CNS, or central nervous system injuries. You can have multiple ocular injuries, including use of topical anesthetics, recurrent injuries to the cornea, contact lens related dystrophies. You get viral infection, chemical burns, and prior corneal surgery where we actually transect the nerves. I've highlighted in red the 3 most common causes of neurotrophic keratitis that are sent for surgical intervention. These include stroke, brain surgery, most commonly the acoustic neuroma, because the 5th and 7th are so intimately intertwined in the area where these neuromas typically exist, and obviously the HSV and zoster viral infections that are known for causing corneal hypoesthesia. So what goes on when you can't sense? Well, you don't blink properly, you don't produce tears properly, you get repeated trauma that you're not aware of, and you lose the neurotrophic factors from the corneal epithelium. It turns out our sensory nerves are very important for healing because they release certain factors into the tissue when it's injured that help stimulate growth and healing. What do we typically do for the average person who loses sensation? We use lubrications, maybe bandage contact lenses at a time, autologous serum, which does include many of these trophic factors. And there's many experimental treatments in terms of substance P and some growth factor, nerve growth factors that you can buy commercially and are more on the experimental side or the extremely expensive side and require lifetime administration with moderate effect, but definitely some promising effects. So that's the basic treatments. And then if that fails, then we go on to standard surgical or oculoplastics treatments, including tarsorrhaphies, insertion of gold weights, punctal obliteration in the cornea. If there's a abrasion that's not healing or an ulcer that's not breathing, amniotic membrane transplants, sometimes corneal transplants or Boston keratoprosthesis. And unfortunately, the corneal transplant has a high failure rate when there's poor sensation. So you get repeated injuries to the cornea, you develop a scar on the cornea that impairs vision. And then if you were to do a transplant to take out that scar, unfortunately, you develop a high failure rate. And many surgeons feel that complete loss of sensation to the cornea is a contraindication to corneal transplant surgery. So there's many different nerves that we can harvest. This is one of them, the medial antebrachial nerve that's harvested in the arm. And then the other one that we use a bit more commonly is the sural nerve. And I think we have a short video here outlining some of the anatomy of the nerve. That video didn't work, so let me try to go back. So what I'll do maybe is I have a backup computer where I actually have the presentations on a hard drive. So I'll go through the presentation, and if we have enough time, I'll circle back to the videos. And then from going forward, now that I know that the videos aren't working, I'll just switch to that as my primary source. So I'll go back to this video, and we'll jump to this key article that came out in 2015, which was published by that team in Toronto that I mentioned earlier. So this corneal neurotization surgery, what's amazing about it is that it's a Canadian success story. The first group in the world to describe it was a group of Canadians, and now everybody around the world is using variations of this initial technique described by Toronto. Here in Alberta, we were the second group in the world to utilize this surgery. We made some minor adaptations, but we really followed really closely what the Toronto group did. And we were the first group in the world to use this surgery on a large group of adults. I think our first publication was about 8 or 10 adults. And nobody knew if this would work in an adult who have impaired healing, much longer run times for nerve healing, and other issues. So here are some descriptions of the results that we see when we do a corneal nerve graft. So this photograph on the left shows a typical healed neurotrophic ulcer with neovascularization and scarring. And the photograph on the right shows that what we thought was a very dense scar, once you reinsert the nerve, and you can actually, can you see my pointer on the screen? You can see a very thin nerve here. This is after nerve surgery. And after the sensation has recurred, you can see that this scar and neovascularization has improved dramatically, probably about 80 or 90%. And this was a really surprising finding that we found both the Toronto group in children and us, the first to see it described in adults, is what we thought was a permanent scar that required corneal transplant as the only way to fix it, actually would remodel and improve when you reattached the nerve and provided some sensation. So many patients that we initially thought we'd have to do corneal neurotization, and then when the healing came back, would require to go through corneal transplant surgery. Many of them improved enough without corneal transplant surgery to improve their quality of life and function, and kind of have that in their back pocket. So what's the typical timeline? So we take the nerve, we attach it to the eye, into a nerve that hasn't been injured, and on average, it takes about 6 months till the sensation comes back. And most commonly, we reattach it to the supraorbital nerve on the opposite side, and we tunnel the nerve under the nose, under the skin in the nose, over to the good eye, through the eyelid, and to the eye. And so the nerves have to grow from the opposite forehead, under the skin, over the nose, through the eyelid, and back to the eye. So it takes about 6 months for that to grow. Usually, they describe 1 millimeter a day is kind of how the healing happens once healing initiates. What's really interesting is usually within a couple months, maybe 2 or 3 months, the patients will start to describing pain in the forehead where the nerve used to function. So you can imagine if I had a right eye that lost sensation and I attached the nerve to my left forehead in my right eye, after a few months, I would describe pain in my left forehead. And it's kind of an interesting phenomenon because initially when you transect that nerve that's healthy from the left forehead, it goes completely numb. And then a few months later, develop pain. And what they're experiencing is the pain from the ulcer in the good eye, but the brain hasn't remodeled yet. It thinks that pain is coming from the forehead. So it's telling the person, hey, there's something wrong with your forehead, it's injured, but it's actually the eye that it's sensing, which is really, really fascinating. And as soon as I have that experience and a patient tells me that the pain in the forehead is coming on, I know we've won, because now I know that nerve from the eye that's attaching to the contralateral forehead nerve is starting to work. And over time, the brain will adapt and understand that pain sensation, that non-healing ulceration pain, is actually coming from the eye. And then once sensation improves, it doesn't turn into a completely normal cornea. It gets, I would describe it maybe a 50 to 60% improvement from, like, let's say 0 sensation to about half what a normal person would have. Then you start seeing the healing process. And the way we check that is you actually touch their cornea preoperatively, and 6 months later, and they can't feel anything. And 6 months later, you touch the cornea and they can start to feel both light touch and strong touch, demonstrating healing. So to take one step back, I mentioned to you that 2015 was this breakthrough paper from the Toronto group. It turns out in 2009, similar group from Norfolk, Virginia, in the United States, did kind of an older style surgery, but it had some success, which kind of led the Toronto group to do what they did. And what the group did, I'm just letting some people in, I'm getting some messages. The group did in Norfolk is they would do a bichronal approach. They cut from ear to ear, and then they would isolate the healthy nerve from the contralateral forehead, take it off the forehead, and then swing it down into the eye, and then they got improvement in sensation. But there was a lot of morbidity when you make that big of an incision, so there wasn't a big uptake with this surgery at the time. I remember reading this back in 2009, shortly after I started practice, and I was trained in using bichronals for orbital decompression surgery in my time in Europe, and I was thinking about and contemplating it, and then I mentioned it to a few cornea specialists locally, and none of them referred any patients to me for this surgery, so it was put on hold. So when the 2015 paper came out and provided this minimally invasive technique, where you just take a small nerve from the arm or the leg, all of a sudden I got buy-in from the cornea group, and we were able to try it. Now, some of you may be asking, okay, we have drops that make things better. Why don't we just use drops? Why are we using surgery? And the reason surgery has a role in patients with severe neurotrophic keratitis that's not responding to typical surgical management and typical lubrication is the lifelong requirement of the drops, kind of those fancier neurotrophic keratitis specific drops, are very expensive. And if you were to lose a bottle going on vacation or things like that, you would regress and run into problems. Whereas if you do this nerve surgery, if it's successful, then you kind of cure the patient for life. And the idea of a single surgery followed by a lifetime cure is very attractive to many patients, cornea specialists who send patients to me. And one of the major groups, this group here, if I remember, they're from Japan. They're kind of the leading group in the using drops to heal the cornea. They even every time they would summarize their findings, they would say the ultimate cure is to actually get sensation back to the cornea, not use these drops that kind of mimic what the nerves do. So to go over quickly some basic anatomy, you can see that the three major branches of sensation that provide sensation to the area close to the eye are the supraorbital nerve here, which many of us, you can feel that notch if you feel up in your orbital rim, the supratrochlear nerve, which passes right by the trochlea, and the infraorbital nerve. And all these nerves can be used to attach to and provide sensation to the eye. Interestingly enough, in the pediatrics group, the Toronto group were able to use what's called the supratrochlear nerve, which is a much smaller nerve and a less important nerve, and is a good size match for the sural nerve in the leg, because the nerves, when you attach them, have to have a similar size and diameter for things to work. And when I tried these first surgeries in the adult, there was a big mismatch between the small supratrochlear nerve and the large sural nerve. So then we ended up using the supraorbital and published that and kind of updated the groups that you shouldn't spend an hour trying to find this tiny nerve in the adult. It's not going to be a good match 9 out of 10 times. You can save a lot of time and go straight to the supraorbital nerve or the infraorbital nerve, which are much easier to find and utilize those. Here's this 3 small incisions that we use for harvesting the sural nerve. And we make 3 cuts, and you can see here, you basically cut the nerve up high, and then you kind of release it from all the surrounding tissues, and you pull it through the second hole, and then release it from all the tissues, and you pull it from the third hole. And you can see how this is the nerve that goes from basically all the way from here to there, and allows you to have as much length as you need from getting across. This is a very commonly used nerve by the people like orthoptics and plastic surgery when they're working on motor nerves after nerve injury. And that's because all you lose is sensation to the outside part of your leg. And it usually people heal quite well. And back in 2011, I had a bad injury, a fall, and I had some bones break out of my skin and transect my sural nerve. So I have a sural nerve graft injury. And I can tell my patients what it was like and how long it took to heal from it. And that kind of helps them with their decision making as well in terms of what to expect. I wish I didn't have that experience, but we use what we have. So how does neuroregeneration grow? How do you take a nerve, reattach it, and then expect things to actually heal or work? So what's interesting is when you harvest a nerve, you're harvesting this picture on the left here, which is the entire nerve itself surrounded by this protective sheath. And then within the sural nerve, there's between 5 to 8 what we call fascicles. And here's one kind of drawn out, sticking out, and those have their own protective sheath. And within them, there's hundreds of thousands of axons, nerves themselves. So in brief, what you'll do is you'll take out a nerve, you'll reattach it on one side to a healthy nerve, and on the eye, you'll reattach it to the eyeball. And I'll show you a video once I get my videos working properly on how to do that. And then all these axons, all the nerves that are harvested from the leg or the arm end up dying. But the support structure of the nerves, all this casing, survives. And when the healthy nerve senses that casing, it says, hey, I have a nerve injury. I'm going to send my axons down this casing, down these tubes, and pass and slowly grow down these tubes until I get to the other end. And that's how our bodies heal from minor nerve injuries. If you hit your arm really hard and damage a nerve, you might lose sensation for a few weeks or a few months while it heals. This is an extreme version of the same thing, and it's called Wallerian regeneration. And on the right side is a picture of the axon sending out this microtubule, which kind of finds its way down the tube and then reattaches on the other side of the tube to in this case, the eyeball or whatever other structures. So that's kind of the mechanism of healing Wallerian regeneration. And this process is, like I mentioned earlier, is 1 millimeter a day. And that's why it takes up to 6 months till we get full healing. Okay, let's see if this video works. Oh no, actually I think this is a table. So yeah, it's a table summarizing our first 9 patients. So what we did is, it was interesting. It was a kind of a good story. I was full-time faculty at the U of A And one of our medical students was doing summer research with me, and he was a very strong student, and he ended up picking plastic surgery as his specialty and was training and doing his residency in Toronto. And he sends me this email saying, hey, this is some fantastic surgery that we've been doing here on kids. I thought you'd be interested in reading it. And so 2 weeks before the paper was published, I got my eyes on this pre-release, I read it and I was fascinated. And so I called the surgeons in Toronto and talked to them about it. And I think on the same week that it was published, we performed our first surgery here in Edmonton. By chance, I had a patient come in like the same week that I got this article that was failing all maximal medical management, maximal standard surgical management, and it was their only eye. And so we tried this Hail Mary pass and succeeded. And so then we did 9 in a row, adults who were sent in very similar, very challenging situations, and were successful. And I think it was 8 out of the 9 patients. And then we said, okay, this is real. Let's publish this. And then all of a sudden people knew that this also worked in adults. To qualify this, you can imagine that you have this radically new surgery that doesn't even make sense to many of us in ophthalmology till you try it. And you have patients who are really suffering, and let's say they only have one eye, they've already lost another eye, and their life, the quality of life is horrible, and they're about to lose their only eye. So that's the type of patient that we try this on initially, because those are the only ones we had ethical approval to try this experimental surgery on. So let's describe the first 9 patients. Mean age was 57 years. As I mentioned, it was the first series of adult patients. The mean time that the patients lost sensation was about 2 years. So they've been struggling with maximal medical and surgical management at the time for about 2 years before they were sent to us. They were followed up for a minimum 6 months. The mean time involved was about a year when we published this. Actually, the initial series, all 9 patients had improved corneal sensation within half a year following the procedure. 5 patients out of the 9 had significant improvements of their visual acuity without any secondary surgery. And so it was quite promising. 1 patient underwent cataract surgery at 13 months, and another one had amniotic membrane grafting at 17 months following neurotization. So those are kind of the secondary surgery outcomes. And then subsequently, we published another case series on the first 22 patients that we did that had very similar outcomes. So let's look at these first 9, and let's look at first at the causes. So trauma, multiple retinal detachments, repairs, zoster, acoustic neuroma, zoster, type 1 diabetes, herpes simplex, and post-traumatic. And you can see the vision, the preoperative visual acuity here. So most of them were like in the hand motion, counting fingers, 2300, 2500. This was kind of the best one. And it was kind of our last one we did in our initial series because they were much better than the other ones. And the epithelial status on this initial one had a central scar, but was healed. You can see many of them had active ulcers, about 2, 3, 4, 5, had 5 out of the 9 had active ulcers, and the rest had scarring and healed corneal ulcerations. This is the follow-up time. You can see the minimum was 6 months. And the last visual acuity was here in this table here. And let's ignore patient 7 for a second. You can see that patient 1 went from 2060 to 2040, 2800 to 2160, hand motion to 2025 after the cornea healed and had cataract surgery, 2300, 2070, 2050, this person got worse, 2070, 2100 to 2080, 2300 to 2060, and 2500 to 2070. So pretty dramatic improvements. The reason this patient stayed at counting fingers is unfortunately they passed away 4 months after the surgery from diabetic related complications, not surgical complications. They were severe type 1 diabetic who died at a very young age, 4 months after surgery. And this one patient where there was a slight worsening developed a traumatic injury to their cornea shortly about a year after and then developed a scar from that, so their vision went down, even though they had some sensation. So that's why I said to I guess one patient died. So let's say 1 out of 8 patients didn't have a great response, and 7 out of 8 did. So very promising surgery. Every single one of these patients was at the end of the line, except for this last one, which was our number 9 surgery. End of the line, only eye or something that made it that they couldn't lose that eye without having massive loss of function in their eye. So when we go over the next, let's expand our case series to 22 cases, and we had a failure rate or a partial response rate of 3 out of 22, and I wanted to discuss those because no surgery is perfect, and it took us once we got into the 20s to kind of get a better idea of the failure rates in the surgery. One patient had a severe autoimmune disease, a variation of lupus combined with rheumatoid arthritis, and developed an OCP-like presentation later on, about a year or 2 after the surgery. So the surgery healed, they got corneal sensation, their vision improved, but then they developed this unrelenting bilateral ocular cicatricial process and lost both eyes. And us in rheumatology were unable to shut this process down. Case 2 had very mild improvement sensation, had no reduction in scarring, but did have reduction in repeated episodes of corneal breakdown, but the scar did not improve. And the cornea surgeon felt uneasy about transplantation because the sensation wasn't great enough. Interesting, on this case, it was a herpes simplex virus, and we used the ipsilateral supraorbital nerve to try to speed up healing response. And because we know herpes simplex can affect say the different branches from the 5th cranial nerve, even though their forehead was tested as completely normal preoperatively, they might have had an abnormal supraorbital nerve on that same side. It might have been a technical error. It might have been better to go to the opposite side. And case number 3, no documentation of improvement. My guess is when we reattach the nerve to the healthy side, there must have been a surgical dehiscence or something along that line, because there was absolutely no improvement, and that was the only case of 22 that had no improvement. Here's some pictures on a slit lamp of what these little fascicles look like once the patient's healed. So in conclusion, our series of 22 severe patients, 19 showed dramatic improvements. Surprisingly, what we thought was described as scars that could not improve, many of them did improve. Of those that didn't have visual acuity improvement, all but 2 of the 22 were now reasonable candidates for corneal transplantation surgery where they were not prior. We had no major complications or even significantly minor complications at the time of surgery, so this is a low morbidity surgery. And our experience suggests that these nerve transfers are good solutions to these very challenging cases. One thing important to talk about, our first 3 or 4 cases, when they went from 0 sensation to amazing sensation. Like you could take the finest suture thread or tissue paper and they could feel 360 around the cornea. And I think we had a bit of beginner's luck. After that, we had many cases where they would get partial recovery, where certain parts of the cornea had better sensation than others. Other parts of the cornea might not have complete sensation, and that has to do with the technical aspects of the how we do the surgery and the different fascicles. But the good news is we found out that you don't need 100% recovery to completely normal sensation to have dramatic improvements in vision and do well with corneal transplants. You need moderate improvement. And nobody knows exactly what that threshold is, but we definitely see that the vast majority of our patients reach that threshold. Okay, so maybe maybe I move the video to here. So here's just a picture of harvesting the medial antebrachial cutaneous nerve. I think we still have some time. So you can see the anterior branch and the posterior branch, and you just need a nerve stimulator to make sure you're not taking on the sensory nerve. You harvest the anterior branch, close them up quickly. And this is kind of a fast forward version of how it's attached to the eye, just to save everybody some time. So basically I create a pocket in the subtenon space, then I connect that pocket with the eyelid crease approach. And then I do a 360 dissection, trying to preserve the blood vessels at the limbus, because that's where the fascicles will be reattached. I have a slower version of this. I'm not sure why it's so fast. I don't know how to change the speed. So here's the nerve after we've harvested, and we're just taking a Van Ness scissor and kind of separating what we called about those fascicles that we showed you earlier. So you can see it's with one nerve, and slowly we're going to divide it into all the fascicles. And I'm just going to try to speed it up. It's downloading a bit slowly from the cloud here. And you can see we're just getting rid of all the excess tissue that we don't need. And soon you'll see the actual fascicles coming together. I'm just going to jump forward again. All of a sudden now we're starting to see the fascicles. I'm laying it on the cornea. And then I pass it. You can see how we pass it. We made these small openings in the conjunctiva, and we pass the nerve through the ends. And then we only touch the tips of the nerve, because that obviously damages them. And then right before we suture them, we kind of cut off that damaged tip. Didn't realize how fast this is. It's kind of painful to watch so fast, but we'll get you guys home earlier. And I use a 9-0 Vicryl, and this is kind of one of my first ones. I've kind of altered my technique now, and I use now kind of a variation of a horizontal mattress suture, where I take the end of the nerve, I go into the sclera, come out the cornea, go back in the cornea, come out the sclera, and suture the fascicle to the scleral/corneal junction. And then also what that does is it traps the conjunctiva on top of my nerve to ensure that there's a blood supply and reduced risk of suture breaking down and exposure of that nerve to the air. This surgery now, I do it as a team. It is if you do it by yourself, it's about 3.5 hour surgery to 4 hours. It's very easy to learn how to harvest the nerve. I do it with a colleague, a plastic surgeon, and she'll harvest the nerve while I dissect the nerve and do the eye. So we can do it in under 2.5 hours. It really saves a lot of time. We just book it first case in the morning. We're actually doing one, I think, on Wednesday this week, on a child who was born, it was a post-brain surgery, tumor resection. We're doing one this week, and hopefully that child will heal nicely. I'm going to jump forward a little bit. Now I'm just closing up the conjunctiva, and you can see how the fascicles will put in different clock hours to try to get sensation in different areas. And my guess is sometimes the fascicles will fail, and that's why you get segments of recovery in some areas that don't. We've all seen conjunctival closures, so I'll try to jump. So now what we're doing, see the nerve is hanging out on the same side as this is the bad eye. Oh, sorry, this is actually the contralateral side here, where this is a supraorbital nerve, and I just cut it, and I'm pulling it down, and then there's that nerve, and then here we don't have to split up the fascicles, so it saves a lot of time. We just suture end to end with the nerve here. And then after we suture end to end, we just suture the outside and then just put some tissue glue on it. So it's pretty quick, this part. I'm just jumping a bit here. And this video unfortunately doesn't show kind of the pathway. Here's a bit of tissue glue. and then we just close the skin. Oh, that's because this is an ipsilateral. Okay, and advancements in some centers now, instead of harvesting the patient's own nerve, you can buy cadaveric nerve tissue, and it saves the harvest process and saves a lot of surgical time and reduces the loss of sensation from wherever you're harvesting the nerve from. The downside is the world of nerve graft is divided into two camps: those who think this is a good option and those who think it's a bad option. And the person who taught me how to harvest nerves and reattach them in Calgary, a plastic surgeon I work with, she's in the camp that doesn't believe strongly in this. But I am on one of the third case that we talked about that was a failure. I've offered that patient a cadaveric nerve graft to reduce morbidity. And maybe in 5 or 6 years, the verdict will be out about how good these are, but the team I work with aren't huge believers in it. And that's why we haven't done it yet. Okay, this is I just added this one very quick video just to show you guys kind of how we connect the sides. And then because other surgery was good at showing the fascicles, and this is good at showing how we connect. I'm just jumping a bit here. So just using a suborbicularis dissection plane. And I'm feeling the supraorbital notch. Then I cut down and find this was one of our first cases. We were actually looking for that supratrochlear nerve, that small one, and we found it. And then we measure the length. Okay, so we need about 4 centimeters. This is the sick eye, so I'm making that pocket. That's why I created the other video, because I use the microscope because the lighting is better. But you create that pocket with subtenons, then you connect that pocket with the eyelid crease incision just medial to the medial horn of the levator muscle. And then I take a snap. Let me just go back a bit. I take a snap and I go underneath the skin. And then I go just underneath the orbicularis muscle, underneath the nasalis muscle, just over the bone of the nasal bridge, and cross over to the other side. And I take the nerve, I pass it from the eyelid into the eye. And then you'll see in the next section how the nerve goes from one side to the other. So there's the nerve on the other side. I've already passed it. And you can see how it goes from one side to the other side and onto the eye. And then if somebody has a very large bridge of the nose, you just make a very small cut because your instrument can't get around it. You take it out the skin and put it back in. So pretty easy things to do. And it's surprising how well the surgery works and how it's changed everything. So I'm going to stop the presentation and see if we have time for questions.
Do we have some time, Joel?
We sure do. Yes, go ahead if you'd like, Dr.
Okay. No, thank you so much, Ezekiel. It's such a great technique. I'm fortunate to share a mutual patient that I've seen of yours that's doing really well. And I just had a couple of questions, quick ones about nerve preference. You working with a plastic surgeon so that she's harvesting. Do you base it off the patient, or are you kind of going with kind of what's your thought process between which nerve you like to take?
Yeah, it's interesting. I'm very open-minded, and I came into this with no history, right? We were just kind of jumped in into the deep end of the pool, and without any history or knowledge or understanding about the 50 or 60 years of these different camps about which nerve is better. So basically it comes down to a good size match with the supraorbital nerve in an adult. And the two, if you're going to harvest, the two ones that make the most sense to me when we review this in detail are the anterior medial one in the arm and the sural nerve in the leg. And it turns out that if you're getting I would not be experienced enough to start harvest the one in the arm. And there's lots of motor nerves there. So I would not use that one myself. I would do the sural nerve because it's so easy and safe and there's nothing dangerous in that area. So if I was doing it myself, I would be stuck doing the sural nerve based on my skill set. if they had a plastic surgeon whose specialty was microsurgery and nerve grafts, and that's what who I partner with, they will base it on their preference. And some have a huge preference for going the arm, and they'll give you 50 reasons why the morbidity is lower here. And then some have a preference for the leg, and they'll give you, 49 reasons why that's better.
Other ones.
And
Yeah.
the reason I had experience learning about the arm one is because my regular surgeon went on maternity leave, and the lady that was covering for her just trained in a different school where they focused mostly on the arm. And
There you
so
go.
that's kind of how I got exposed to two. So I don't have much preference. They're
Okay.
both long enough for ipsilateral or contralateral.
Okay, perfect. And then for kids, if anything pops up that in your mind makes one a better fit than another,
For
or
kids,
same idea.
For kids, I have a preference for the leg, because I with a bandage on the leg, I just think there's a less risk of them breaking down the wound and reaching down and doing some harm.
Yeah.
That's kind of my preference. Some would say otherwise, because kids are getting more traumatic injuries to their legs, so there might be more healing responses to the leg, but I haven't seen that yet. And the Toronto group hasn't seen that, and they've done way more children than I have.
Okay.
So I think I would pick the leg in the child, the sural nerve.
Okay. And then, sorry, just one last one. I'm sure I'll ambush you at a future meeting as well. But as far as your local, are you a little more judicious with how much you use, worrying about any epi effect, or since the nerve essentially dies anyways, you're not so concerned?
I actually don't use local at all for these cases. We do in the harvesting location, and but not up at the eye, because I'm doing under general anesthetic, and I'm worried about a hematoma making the dissection plans a little bit difficult. But I wouldn't be against it at all. But you just have to be very meticulous applying pressure after, because once you get a big hematoma and you want to make sure that nerve is underneath the orbicularis, so it gets that blood supply over top of it, I'd be worried that I might not be in the plane that I wanted to be in.
Gotcha. Okay, great. Yeah, no, I think it's a great procedure. I'm looking forward to getting a little more exposure to it in the future. So
Perfect.
thank you so much.
Carson. And for those of you who don't know Carson, and I had a lot of chance to interact with his Calgary, and he was a wonderful contribution to our department here.
Thank you.
All right, Dr. Aragutla.
Hi, I'm Vasudha Aragantla. I'm one of the pediatric ophthalmologists here. Thank you for a really fascinating presentation. We don't often see this kind of stuff in pediatric meetings and strabismus meetings, so it's really nice. I have a question about prognosis. Is it different when the etiology is systemic, like diabetes, versus if it's local, either ipsilateral or, but limited to a certain dermatome versus if it's systemic? Thank you.
Yeah, excellent question. Our group and a few others are trying to partner together to get enough cases to actually answer these questions, and unfortunately we don't have answers yet. So I can give you just personal experience, somebody who's done about 40 of these, so kind of take it with a grain of salt, because we might learn a lot more in a few years. Definitely the children heal 100 times faster and better than the adults, irrespective of the etiology. The outcomes in the children is just phenomenal. It's just amazing. And I've had both congenital kind of neural development issues. I've had traumatic, I've had diabetics, I've had everything in the children, and they just seem to just do so well. And the adults, my guess is because many of the patients I'm doing are like severe diabetic, vasculopaths, severe facial injuries with altered blood flow in the areas of the surgery. We're seeing slower and more partial healing in the adults than we do in children. I think for us, it comes down, I think so far we can explain our findings just like on simple common sense. Like if a patient has had a massive facial trauma and the blood supply of the face has been altered, or is a severe diabetic, they're going to heal poorly and slowly, and their prognosis is lesser. But we haven't found a group yet where we say we don't expect any improvement, or we don't expect worthwhile improvement. So we're still doing it on all those patients and still seeing reasonable results. So future might provide some more answers.
Okay, thank you. Dr. Rubat.
Good morning, Dr. Weis. Thank you for very amazing presentation. My question is, how do you measure corneal sensation? And second question is about the minimum age for the pediatric cases.
First, I'd like to thank you for taking care of so many of my patients and doing an amazing job with the patients who have diplopia. So thank you. And second, in terms of we don't have a minimum age, but I think the youngest that we've done around 1.5 to 2. And most of the time I've noticed that for the really young children who have sensation issues, we can most of the time buy time with conservative management and get them through kind of a rough spell. But I'd be happy to go in on somebody younger if the cornea was failing and we're worried about amblyogenic potential and so forth. And I think if I got somebody really young, you know, like 6-7 months, I would just run it by some people. There's about 3 or 4 centers in the world who have a lot of experience. I'd run by their experiences to see if it's an age category I had not operated on yet, but I don't think there's any issues. And sorry, the first question you said was?
How do you measure corneal sensation?
Oh, yeah, so I'm a simple oculoplastic surgeon. So when I started these surgeries, it was kind of, as we would say, kind of down and dirty. I would use a tissue paper, like we split it, rotate it, and that was fine sensation. And then I used a Schirmer strip for measuring heavy sensation. We have purchased one of those aesthesiometers since, the Cochet-Bonnet, because a bunch of the journal articles that we submitted for said, if you don't have a Cochet-Bonnet, we don't know how much improvement it is, so we would measure it that way. I believe since we don't know what the threshold of improvement is, like how many millimeters on the Cochet-Bonnet is associated with how many quadrants is going to result in good healing, I think it's all just descriptive at this point. Our real examination is whether there's improvement in the scarring and whether there's reduction in epithelial breakdown and whether there's some sensation. So it's a good question, and we don't have yet that kind of magic number that you've healed enough that now we know you're going to do well. But hopefully we'll know that in time too.
Thank you.
Are there any other questions from the floor?
Just one more quick one if I have enough time. So post-op, a patient came in, you know, a year post-op, well healed, doing very well. Cornea's sensation is great. She's really wanting ptosis repair. Now she does have a moderate amount of ptosis. MRD1's about 1. So I was hesitant, not wanting to expose more of the cornea. So I went into her repair, telling her I'd purposely be undercorrecting a little bit, just enough so she'd clear her pupil. She was happy with that. Any other type of precautions you maybe take, or do you just flat out say, look, we worked our butts off on this surgery. We're going to deal with the ptosis a little bit longer?
No, I haven't. I've just done cautious ptosis surgery with a goal of like an MRD of like 2 to 3. I don't try to go for 4, just like you said. And in my mind, I'm very conscious about where the nerve's going, how it's going from that supremedial subtenon space into the eyelid. So I would do no posterior medial approach. I'm more of an anterior person anyway, but I would avoid the medial area as much as possible, and just use a cold steel for the dissection because you want to reduce the thermal injury for that nerve that's passing close to the medial aspect of the levator. So I'd probably warn the patient that there might be higher risk of contour issues because I'm not going to be digging around way medially if there's a bit of a peak on that lid.
That's exactly what I told her too. I was like, look, I typically aim for my contour to be a little more medial, but for you, I'm putting it lateral because we gotta avoid all the hard work that's been done. So okay, I just wanted to make sure it wasn't a a full indication because the
Yeah, no,
literature is not so strict about it.
Yeah, I've gotten away with it a couple times, so it should be okay.
Okay, perfect.
Okay, thank you, Dr. Weis, for that very interesting K lecture.